Good evening, everyone. This is Dr. Tamara-Kay, and I'll be sharing with you treatment planning from the pediatric perspective. So I've also sent over the slides for you all to review as well. So treatment planning is really something that you all probably have tackled now in other courses. And so I'm just gonna layer on a pediatric perspective. This workflow was from a pocket guide for treatment planning. It was in the dental pocket guide. So just something for you to reference overall in how you approach treatment planning with your information gathering, evaluation of your findings, and generating a problem list or diagnoses. And then whatever filters like your patient modifiers, dentist modifiers, and then coming up with the treatment plan and so forth. And then lastly, maintenance and monitoring and prevention. So we'll walk through this. I'm going to make it a little bit more robust and focused on pediatrics. So information gathering, of course, you're going to gather your medical history, including medical records when applicable. Medical history, you're going to have a review of systems, cardiovascular, pulmonary, renal, hepatic, etc., as well as medical conditions, medications, hospitalizations and surgeries, allergies, contraindications for routine treatment. And you may have to request the patient's medical records, do a consultation with their primary care physician or specialist, and you may also want to get clearance. So as far as dental history, this would include their patient's dental records if they've been seen somewhere else. Sometimes they may have x-rays or whatever that you may want to request. And part of dental history is just getting that chief complaint. Why is the patient here? What is bringing them into your office for that day? Previous dental treatment, you're going to look for any adjuncts that they've had, such as anesthesia, general anesthesia, sedation, nitrous oxide. Have they had to have anything, papoose, in order to get their dental treatment accomplished? And have they had any negative experiences? I recommend putting this actually on your questionnaire when you do an intake. That way you can start that conversation with the parent and just remember to touch on any negative experiences, because that's really going to play into how you choose to manage a child. If you choose to do it in office, refer them out, or maybe look for some advanced behavior management techniques. And then part of dental history will include fluoride, so topical or systemic. You're going to gather their daily home care. What are they doing at home? Brushing, flossing, so forth. Their diet's going to be really important. And then the family dental history. Sometimes you can discover that there's some inherited dental conditions, and you probably learned about these in your pathology lecture for peds. So something that you should definitely consider. Other things that could be included on this, of course, would be trauma. So any history of trauma, any trauma records that they may have from a hospital or another office, ortho records, and then any consultations or referrals that they had in the past from previous dentists. Maybe someone refer them into you. You could review that information as well. So family psychosocial history. So this just touches on overall the education level, the parent and the child. So parental education level may tell you a little bit about their dental IQ sometimes. And then education of the child, I think it's really important to ask about this child. If they're on grade level, if they have any delays. Sometimes parents omit this on the medical history, and you'll pick this up when you ask them if the child is meeting their milestones. That's a great way of asking them if the child is on target with their education according to their age. And you want to also ask about family dynamics. So who does the child live with? Both parents, single parent, grandparents. You want to get the whole dynamic so that you can figure out any legalese that are involved. Who can bring the child to the appointment? Is there a custody battle? Are both parents able to access the records and so forth? And then location, where do they live? Is it close by? Are they going to be commuting to your office? What's the driving distance? Those are things to kind of consider as far as making an appointment and being realistic about when you can reappoint them. And then parental attitude towards dental care. A lot of times parents will tell you, baby teeth are not important, or do you really have to fix these teeth because they're going to fall out anyway? So it's a good time to kind of capture this on the family social history, just gauging their overall attitude towards dental care. That will help you later on when you're going to be sharing the treatment plan with the parent, and also when you're educating them about oral hygiene and so forth. So clinical assessment. I want to just point out as you're gathering all these clinical things that you're looking for, like your extraoral exam, you're going to have findings that you'll document in the chart. Intraoral exam, you'll have findings as well, including soft tissue, hard tissue, occlusion, which may be your overbite, overjet spacing, missing teeth. And then you're looking for caries and pathology, etc. I use the clinical assessment time to really observe the child's behavior as well. And I also scan the child at this time for any issues that may be signs of abuse, that, you know, the way they walk in, how they are around the parent, how they are acting towards me, if they seem withdrawn, overly social, those types of things you want to pick up on during the clinical exam. You're not just doing just your, you know, obvious charting and findings, but you're looking for the overall child and how their approach is to you, how they interact with your staff, if they're approachable, if they're, you know, willing and cooperative. Those are things that you want to observe as well. So caries risk assessment. Now this is critical, and notice how this is done before you take your radiographs. It feeds into your radiographic assessment. So for the caries risk assessment, this really fosters the treatment of the disease process instead of treating the outcome of the disease. It allows for an understanding of disease factors for a specific patient, and it aids in individualizing preventative discussions. It also selects and determines the frequency of preventative and restorative treatment for a patient. And I would also mention your radiographs, and you can also anticipate caries progression or stabilizations. For the caries risk assessment, I recommend the AAPD's tool, of course, and you can click on this link in the lecture to find that. You've also covered this in your other caries, your caries risk assessment lectures with the other part of the dental team. So I would just reference that and just look at what tool you want to use in your office. But you should definitely have something, whether it's a questionnaire that the parent fills out, or something that you actually ask the parent. You want to make sure you have that available. Now remember, caries risk assessment, it affects the treatment decisions that you make for that patient. So again, multiple tools. It helps to determine the likelihood of the increased incidence of caries. So that's what you're looking at. How likely is this child to get new decay? Or how likely is this decay going to be progressing in the future? Those are just things to consider. And then lastly, on your information gathering would be your radiographic assessment. So, you know, because every patient is unique, you really have to approach this after careful consideration of the patient's medical history, their dental history, completion of a thorough clinical exam, and assessment of the patient's vulnerability to environmental factors that affect their oral health. So it really is something that you should look at from a overall approach on how you're going to take images. So I always recommend that you follow the ADA and FDA guidelines. That should serve as your tool for just what you're going to do, and it should guide your clinical judgment and professional judgment when it comes to taking x-rays. Something else to consider is the timing of initial radiographs. You shouldn't just base off the patient's age. You should really look at their dental age. And remember, each child has their own unique individual circumstances, so you really want to follow up based on each child. Radiographic screening for the purpose of detecting disease should be performed after the clinical assessment, and again, after caries risk assessment. So just remember that as you're doing your information gathering. So this came up a little bit blurry, but I do have the link here at the bottom that talks about where you can find, if you click here, it'll take you right to this diagram instead of the AAPD guidelines. These are the recommendations for prescribing dental radiographs. What I recommend is, I'm gonna have a whole clinical scenario for you, is that you maybe download this presentation as you're going through the scenario on your own. Just try to see if you can maybe reference this so you can pull up what would be appropriate for that child that we're presenting on. So this, I like this a lot because it goes by the child's dentition, you know, so it doesn't talk about age here, it talks about dentition. Prior to eruption of first permanent molars, after eruption of first permanent molars, prior to the eruption of third molars, and then the patient, the recall, right? Is it recall with clinical caries or increased risk for caries? Is a recall with no clinical caries and not an increased risk for caries, and so forth and so on. And so you would follow this grid to just identify what radiographs are indicated for that child based on their risk factors, based on their developmental stages as well. So a treatment plan should be well organized, carefully organized, and sequenced. It's a series of services that are designed to eliminate or control etiological factors. It's the schedule and sequence of the treatment which has been outlined. It creates a response to the problem list. And so we'll have a problem list that comes after we have all this information gathering, right? It means developing a course of action and setting like a goal that encompasses the ramifications and sequelae of treatment to serve patients' need. It's also a blueprint for case management. And so this is a really great article. If you click on here, that kind of talks about treatment planning, and I got this from that article. So just think of it as your overall blueprint. So a good treatment plan, it eliminates decision-making about what you do at each appointment, and it helps the staff plan equipment and materials. Your staff will love you for having a clear and defined treatment plan because it really keeps them on task, and it helps them to prepare for you before you even come in the room. They know what's going to be done. They can have those conversations at the front desk with the parent to collect any fees as well. So it specifies the number of appointments and time required for each appointment. And again, we just talked about this, allows business staff to arrange payment fees, which is important. And you'll see that when we talk about the clinical scenario. So identify components of the child's treatment, types of treatment. So there's preventative treatment, so that may focus more on diet, nutrition, oral hygiene instructions, your fluoride and preventative regimens, SDF. Behavior management, again, we talked about just observing the child throughout the initial appointment to see where they are and what they may need off of the behavior management menu to get through the treatment, or do you need to refer them out to a specialist? Restorative care and surgical care, orthodontic space management, and others, perio and prosto. So for pedo, we are always dovetailing orthodontics into our treatment plan. We are treating the child based on whatever future orthodontic needs they may have. So we don't want to get stuck investing time in treating teeth that may need to be removed because of ortho. Or maybe they may need to save some teeth to help with space management to prevent them from needing additional ortho. So it's really just a balancing act to make sure that whatever tooth you're working in, overall you think about how that tooth fits into the child's orthodontic and space management plan. So other things to think about when treatment is needed, how do you sequence treatment? So there are many approaches, and what we recommend when we teach in this UWI program is that you do quadrant dentistry. We'll touch on it more as I go through the slides, but basically dividing the mouth into fourths and trying to tackle all teeth in that quadrant when possible, when the child is cooperative, when it's reasonable and it can be done in that period of time in one setting. Another approach is doing the worst first. So if a child has, pain in one area of the mouth, or if you notice that there's possibly teeth that may, we say blow up in the future, then you may want to tackle that quadrant first, that tooth first, those teeth first. Or do you want to try an easy appointment? You're still learning how to deal with pediatric patients, so maybe it would be good if you give that child a very easy first visit so that you also have time to kind of win that child over, and you're doing something simple that doesn't really require them to be numb or sit for very long, or it's less invasive, so you have a more pleasant visit, and then you build on that for the next visit that may be harder. So answering this question involves personal preferences, yours as a clinician. Your speed, is it fast enough to do something? Do you feel comfortable moving forward with this difficult procedure, or do you want to do something easier? And then the individual treatment plan philosophies. So we'll talk a little bit about quadrant dentistry. So this just shows, the baby teeth here in this quadrant. You're dividing it for a second, third, fourth quadrant. So you may tackle the upper right quadrant, or the lower right quadrant, or the upper left, the lower left. This same thing with permanent teeth. So in kids, it's a lot easier. Normally you're only tackling maybe up to 3 teeth at one time. So usually it can be manageable if you feel comfortable doing it that way. Completion of all required procedures in 1/4 or quadrant of the mouth is what's called quadrant dentistry. It reduces the number of times local anesthetic is used. It makes maximum use of time available, and it's economically beneficial as well. So that's what we recommend. However, from what you do to what you say may not be as easy. So we recommend it, but it may not always be ideal or easy to do. Another option is to divide the mouth in half. So just going vertically, you would do, the right side or the left side. or horizontally doing all the maxillary arch or all the lower arch. And I think if you're going to take this approach, usually it's when the child has maybe teeth that don't need to be anesthetized is a possibility, or maybe you're only numbing in one quadrant and doing something easy in the quadrant above it. So we sometimes do this on patients, just really depends on their ability to cooperate and if it's practical, feasible, and the amount of anesthesia required, time, modality, and so forth. If you're doing sedation, for example, maybe it's possible to tackle two quadrants if you're not doing too much work. You want to get as much done, but you want to get it done safely. You'll see that in other lectures that they maybe touched on this. And then another thing that comes up often is anterior versus posterior. So posteriors, in our opinion, are most important for chewing and space maintenance and are retained for a longer period of time. So we kind of look at them as more critical, more important. But if you ask a parent, though, they may disagree and they may view the anterior teeth as more important because of aesthetics. When the child smiles, they're seeing this brown spot or dark area in the front, and it's really concerning, and they want to have that taken care of. So you can use this to encourage parents to complete other treatment like their posterior teeth, and then say we'll do the anterior teeth last. Some clinicians refer to the anteriors as a fifth quadrant, meaning it's the last quadrant that they may tackle, or it's just another area of the mouth that they wouldn't include in their quadrant dentistry. So what are your restorative materials? And I won't touch on this too long, but there are many options like here, amalgam, composites as a sealant, crowns, even white crowns like zirconia crowns are an option, tooth-colored materials like your composites or even glass ionomers as well. You're going to want to consider the factors, things to use based on the child's cooperation, how long the teeth will be in the mouth, and how much time you have. And then, do you have good isolation? Where are you? Are you in the operating room? Do you have to be more aggressive? We had a whole lecture on stainless steel crowns. Maybe you're going to place more crowns because you're in the OR, and you don't want to have that child have recurrent caries. So it all boils down to kind of, your setting, the child's cooperation, and just all the different factors with their risk for caries, future caries, and so forth. Choosing material for specific tooth, again, carries risk, the age of the child, the lifespan, size of the lesion, particular tooth involved, ability to isolate, and the pulp involvement. And fluoride content of the material, sometimes you want to go with the glass ionomer because of the fluoride releasing and the recharging. And then the parental preference will be huge for you, as they may influence what you choose to do. But I always say stand firm with parents and let them know what will last. Tell them what your rationale is, and maybe you just agree to disagree, and it may not be a patient that you can serve. They may need to go somewhere else if they're seeking aesthetics and you're trying to do something more practical. Again, aesthetics and costs, and then the presentation, dental needs of the child, restorative procedures required, and the time required to perform procedures. These are all things that you need to talk to the parent about and consider. So total cost for services, preventative measures needed to maintain the completed treatment is also something that you want to factor in. And cost does come into play. Parents will be very honest about what they can afford. And you want to be reasonable, give them maybe give them several options on how to approach treatment, how to break it down. Maybe you don't do quadrants, maybe you do worst first, do one tooth here, one tooth there, but put out the fires. But then I would definitely tell them maybe a payment plan is more indicated and better to do quadrant dentistry so the child doesn't have to have multiple appointments. So you just have to kind of discuss with them what you feel like is best for the child, and then see what you can do to meet them in the middle without compromising what may be ideal for that child. So acceptance by the parents. So when you're dealing with the treatment plan, you want to know what the parent's dental IQ and interest level is. You may have to take the time to educate the parent. I think across the board you should do that, but it may require more intense, in-depth conversations to make sure that you're bringing them up to speed on what is needed and giving them information on the materials that you're using and why may be crucial. Past experiences also plays a role. Finances is huge. And then availability of the appointments. So this is something you want to discuss. That's why you want to figure out how close they live, what the parents' work schedule is, how you can work with them to bring the child in. Sometimes younger kids need to come in the morning, so you maybe want to remind the parent it's okay for your child to miss pre-K. Even if they want to go to Harvard, it's fine. They can miss pre-K and still get into Harvard. And just telling them to kind of balancing what the child needs versus missing school. Overriding medical and social problems, though, really are going to play a role and factor into your treatment planning as well. Sometimes you may have to choose different settings for a patient that has medical issues and maybe medically compromised. You may have to have an OR setting to get their treatment done. If there's any social issues surrounding the family, that has to be considered as well with any treatment that you're doing, what's going to be accepted by the parent. So here are some resources for you to look at. And we'll kind of bring all this together in my next presentation, which talks about a patient case. Well, thank you all for listening. I'll be back in a few just to discuss a actual case.